Exposure to scatter radiation and orthopedic issues related to years of wearing lead aprons in the EP lab has led electrophysiologists to seek out new ways to reduce the need for angiographic X-ray. Reducing or eliminating the use of X-ray imaging not only helps patients, but enhances physician and staff well-being and can be a career extender. The solution is pairing intracardiac echo with newer versions of EP mapping systems that have limited latency issues, so catheter movements can be seen in near real time. Force-sensing RF catheters enable operators to know if they have good tissue contact without the need to see it on imaging. One of the keys to moving to a low or zero-fluoro workflow is having the entire EP staff well-trained to know what physicians need to perform the procedure without X-ray. The Texas Cardiac Arrhythmia Institute in Austin, Texas is doing it well. Dr. Andrea Natale, Executive Medical Director of the Texas Cardiac Arrhythmia Institute and National Medical Director of Cardiac Electrophysiology at HCA Healthcare, and Dr. Rodney Horton, researcher at the Texas Cardiac Arrhythmia Institute, tell firsthand how they struggled for years with back pain from wearing heavy lead aprons, and how he largely eliminated the need for lead by going to a fluoroless workflow. Zero-fluoro workflows are now enabled by advanced EP imaging systems, intracardiac ultrasound, and advances in real-time catheter information.
Before we had really reliable 3D mapping systems, I think that doing procedures without fluoro were probably, with fluoroscopy X-ray, were a little reckless because I just don't think that we had enough feedback and information to be able to put down the X-ray. But now 3D mapping systems have become so effective, and in particular, Cardo has become so effective. I started my journey on fluoroless procedures largely because I became very confident in the capabilities and reliability of the mapping systems, as well as the real-time information with the intracardiac echo. And so having those two really mastered, I think, allowed me to set aside the X-ray without sacrificing safety to the patient.
Well, obviously, the biggest benefit of all the technology that we went through over the year is the integration with three-dimensional mapping system, which has become critical together with intracardiac echo to make the procedure fluoroless or with less fluoro, because we can use the three-dimensional mapping system to kind of create a geometry and deliver lesion on the geometry without using fluoro all the time. So it clearly has been an important component of the evolution of catheter ablation because it gives us a geometry where we catalog all the information that are relevant. So for example, if there is a focal arrhythmia, when the arrhythmia stops, we actually can tag the location and ablate around to make sure we consolidate the effect, which would not be possible with that degree of accuracy without the three-dimensional mapping system. So it clearly is a critical part of the ablation procedure we do today to have the support of the three-dimensional mapping system with the catheter.
My journey for going from low fluoro to zero fluoro began really 15 years ago. And it was a very personal thing for me. I mean, if you look at the reasons that cardiologists and electrophysiologists retire prematurely, the vast majority of them are because of back injuries and neck injuries. So it's basically the wear and tear on the back from the weight of the lead. And that's true. And I was one of those statistics. So I was going home basically barely able to walk some days because of back pain. And so I started on this journey thinking, okay, do I really need to do this? And so for me, and I guess I'm a slow learner, it took me about 5 years to teach myself how to put aside the X-ray. And so I've been fluoroless for all ablation procedures since 2013. And I'm an advocate for it, but I'm not a zealot. So the way I look at fluoroscopy is, if it is helping the patient, do it. Don't do something that is just for your ego, and don't do it if it's only for your health. If it's not sacrificing any safety to the patient, then and you're good at it and you're proven that you can do it, then I have no problem with it. It's nice to not be tethered to the X-ray, not to be forced to use the weight of the lead, not to expose all of the staff in the lab. I mean, the patient as well, but the patient's only getting one procedure. The staff is getting bathed with scatter radiation for day after day after day. And those are not trivial risks to the staff.